Hi, I'm Dr. Amanda Nizam. I'm a GU medical oncologist at Cleveland Clinic, and I'm joined today by Dr. Antonio Cigliola from Institute San Raffaele in Milan.
Hi, I'm Antonio Cigliola. I work in San Raffaele Hospital as oncologist in the group of Professor Necchi.
And we're here to discuss his abstract that was presented as a late-breaking abstract here at ASCO 2024 about neoadjuvant sacituzumab govitecan in the SURE-01 trial, and that was in cisplatin-ineligible patients or declined patients. So could you tell us a little bit about your study that you presented here at ASCO?
So in SURE-01 study, patients with CT2, 4, and 0 histological confirmed urothelial carcinoma who were ineligible or refused cisplatin-based chemotherapy received a baseline assessment with the UGT1A1 test, CT scan, bladder MRI, and FDG PET, and underwent 4 cycles of 10 milligram per kilogram sacituzumab govitecan. Then patients received the same assessment of the baseline and then underwent radical cystectomy. The primary endpoint of the study was pathological complete response rate, while secondary endpoints were pathological downstaging rate, safety, quality of life, and EFS.
And did you have any unforeseen circumstances or amendments in the protocol as a result of the trial?
Yes, after the initial 8 patients, the protocol was amended due to several cases of G3/4 neutropenia and diarrhea, and 2 deaths, 1 treatment-related and 1 unrelated. And so with the amendment of the protocol, there was a reduction of the dose of sacituzumab govitecan to 7.5 milligram per kilogram, and the introduction of GCSF as a primary prophylaxis for all patients from cycle 1, day 9.
Very good. And how many patients went on to, be eligible for the safety population and also for the primary endpoint population? So in terms of intention to treat population and also those who actually went on to receive radical cystectomy. Could you tell us a little bit about that?
18 patients underwent surgery. Of them, 7 of them refused radical cystectomy and underwent RE2RBT due a clinical complete response after the neoadjuvant treatment. And so considering radical cystectomy available patients, pathological complete response rate was 36.4%, while considering the intention to treat population with the patients who received radical cystectomy or RE2RBT, pathological complete response was 46.7% with a pathological downstaging in 11 patients. And a very interesting finding of the study was that all patients with a high-risk residual disease revealed a CT negative Signatera test after radical cystectomy.
Mm-hmm. So what do you see in terms of, did you find anything else in terms, so the safety obviously findings are very concerning, especially when we're treating patients in a curative state. What else did you learn from biomarker studies in terms of who was at greater risk for the neutropenia?
We performed 12 patients UGT1A1 polymorphisms, and we saw that the patients with an homozygous UGT1A1 28 polymorphisms had more toxicities than wild types 1.
Mm-hmm. And what do you see with the new TROPiCS-04 data that came out in the metastatic setting? Where do you see the role of sacituzumab govitecan in either the neoadjuvant or adjuvant setting? I know there's the SURE-02 trial that's looking at perioperative SG, which we'll talk about in a little bit. But from this study, what is your biggest takeaway in terms of the role of SG in this population?
Okay. Thank you. Our study supports the use of sacituzumab govitecan in this setting. In the same time, we need biomarkers of response to neoadjuvant or to sacituzumab govitecan. Our biomarkers analysis, although preliminary, showed that patients with a complete pathological response had tumor samples which were enriched in BRCA2 and ARID1A mutations, while those from patients without a complete pathological response were enriched in HER2 mutations. Probably in future we will have more information about this topic.
Yeah, so certainly a lot to learn from biomarker studies in these patients, and especially in the cisplatin ineligible or cisplatin refused population where there is no standard of care chemotherapy currently. So as part of the SURE study, there's a second cohort, the SURE-02 study. Can you tell us a little bit about that and what you envision to look at in that study?
We are waiting the results of the SURE-2 study, in which we are considering the same population, and so patients with a CT2-4 and 0 histological confirmed urothelial carcinoma ineligible for cisplatin-based chemotherapy, but in this trial we are using immunotherapy with Pembrolizumab together with sacituzumab govitecan in the neoadjuvant setting, and after radical cystectomy patients will receive adjuvant immunotherapy for 1 year.
And this is against cisplatin ineligible population?
Yes, it's the same cohort of patients.
Good.
Yes.
Very good. And then what other correlative studies do you have planned with the SURE-01 and SURE-02 trials?
We are awaiting the final study, the final findings about this study. Our preliminary results are very promising, and so we expect to have positive results from SURE-01 and SURE-2 study, in both studies.
Okay. And then in terms of correlative analyses?
In terms of quality of life?
Quality of life, and then ctDNA, other biomarker studies that you plan to do?
Yes, we will perform NGS to all patients to try to find biomarkers of response in this population of patients.
Okay. And then in the SURE-02, because of the toxicity complications that came up in SURE-01, was the protocol also changed to mandate G-CSF prophylaxis?
We used the same, primary prophylaxis, exclusion of patients with greater than or equal of 3 risk factors for febrile neutropenia, and the same dosage of the SURE-01 trial with 7.5 milligram per kilogram.
Very good. Is there any other big takeaways you'd like to share about this study? In the greater context of our field?
Yes. Yeah. In terms of safety, we saw that patients who had a lot of toxicities generally had most of their toxicities after the cycle 1. And so probably in future we can consider to use the same dosage of the other cancers, so 10 milligram per kilogram, to those patients who didn't have a lot of toxicities after the cycle 1 at 7.5 milligram per kilogram.